and welcome to the CAP 22 media briefing. Thank you for joining us. My name is Dr. Emily Volk and I am the president of the College of American Pathologists. The CAP represents over 18,000 board-certified pathologists, and the CAP accredits over 8,000 clinical laboratories worldwide, assuring patients and the public that testing performed in a CAP-accredited laboratory meets the highest standards possible. We are live here in New Orleans at the CAP annual meeting. We are also closing out 2022 with COVID still claiming the headlines, along with changes in COVID at-home testing guidelines. Also sharing those headlines is the yearly flu season, vaccines, monkeypox, and what is really concerning to the medical community, the resurgence of polio and Ebola. Pathologists are at the forefront of all of these illnesses because a diagnosis emanates from the clinical laboratory. Before we begin, for members of the media who are joining us, please submit any questions for our pathologists in the chat box during the briefing. If we don't get to your questions because of time, be sure to follow up with CAP Media Relations team, and we will get those questions answered. First up, we want to take a deeper look on a topic critical to all of us, the blood supply. We certainly know we can't live without it, but it seems we are always coming up short when it comes to having enough of it. Joining us this morning for this discussion are CAP members Dr. Julie Cruz and Dr. Julie Karp. Also, Dr. Glenn Ramsey, who is joining us virtually. Welcome to all of you and thank you for being here. Dr. Karp, could you please introduce yourself?
Sure. I'm Dr. Julie Karp. I am a physician at Thomas Jefferson University Hospital in Philadelphia and a proud CAP member.
Dr. Cruz?
Sure. I'm Julie Cruz. I'm the Senior Medical Director for Versity. We provide blood and laboratory services throughout the Midwest and across the country.
Awesome. And Dr. Ramsey?
At Northwestern University Feinberg School of Medicine here in Chicago. And myself and my fellow panelists are current or former members of the College of American Pathologists Transfusion, Apheresis, and Cellular Therapy Committee. Thanks.
Thank you. I'm sure you're all eager to discuss this topic. It seems to me that we do see news coverage when there are critical blood shortages. But the question remains, why are we always struggling to keep up with it and have an ample blood supply? What kind of pressures do these constant shortages create for blood banks and blood bankers? I'd like for all three of you to weigh in, but I'll start with you, Dr. Cruz.
Sure. The first and foremost thing is that blood is perishable. So we need a constant supply of donors. For platelets, it's a week or less, and even for whole blood, for red cells, it's the interval in which the blood expires is shorter than what a donor can donate. So we constantly need new people. Folks age out of their ability to donate. They become patients rather than donors. So again, we need to continuously support the blood supply with new donors, younger donors, and just replacing what has been used or will be expiring.
Dr. Karp.
I think as far as the pressures on hospitals and on transfusion services, it's really just being nimble. There are weeks where the supply is adequate and we can do business as usual. And then there are weeks or times, sometimes more than weeks, where things are a little more tenuous. And we need to be really very on the ball about how we're managing our inventory. That might be communicating with our physician colleagues more frequently, providing more up-to-the-minute updates about what our current inventory is, and having conversations about how we can make sure that every patient who needs what they need gets it.
Absolutely. Dr. Ramsey, your thoughts?
Well, we've had a lot of ups and downs in the COVID pandemic here, ups and downs with regard to patient needs, donor availability. In some cases, at the same time, we are trying to come back with our medical services for patients who have deferred their care because of COVID and various things around that. We also face a shortage of blood donations. So there's this supply and demand issue that's constantly needs to be addressed, and the medical community really needs the blood bank support for many different kinds of medical treatments and surgical treatments that we do every day.
You know, I'm not sure that everyone realizes that donor management is a big part of blood banking. Can you tell a little bit more about what we can do to increase donors, change the engagement of the current donor population, and add to it, and also talk a little bit about some of the recent changes in blood donation restrictions and donation deferrals. I'm sure most folks are not familiar with these deferrals and these restrictions to blood donations. And how are these deferrals evaluated and decided upon? Dr. Karp, I'll start with you.
Sure. Let's talk about deferrals first. Deferrals are an important part of what we do because not everyone is able to donate blood. The deferral might be to protect the donor. It also might be to protect the recipient. In other words, that the donor has either a medication or some other issue that would potentially create harm in a recipient of their unit. So we are very careful about who we allow to donate blood because we want to make sure that, that the blood is of the highest quality and also of the highest safety. So not everyone is eligible to donate. The rules on who is and who is not eligible to donate are largely dictated by the FDA, so at a federal level. There can be local variations, but those are usually relatively minor, and at least in the United States, most of the rules are fairly consistent across. As far as engaging donors, I think the biggest issue is just education. To Dr. Cruz's point, the idea that blood is perishable, we need people to donate blood every day because if people aren't, that blood supply does dry up pretty fast. It will expire. And so I think that educational piece is probably the most important part to make sure that they know how needed they are.
So can you tell us a little bit more, Dr. Ramsey, about how, pardon me, Dr. Cruz, can you tell us a little bit more about how you encourage blood donors to keep coming back, to do it the first time, but then come back and do it again and again and again?
Sure. It's really important because only a small minority of folks who are actually eligible will donate, and we really need to increase that level. We kind of want to do that by getting folks to be blood champions, so not just thinking about donating themselves, but recruiting their friends, their family, their communities to donate blood, because you never know when it will touch you personally, and that's how we can all kind of be responsible as a community together to each other. The deferrals that have expanded really came about in the past year, so that we were given some shorter time frames for some of the deferrals, and some were removed. So the best way for folks to find out if they're eligible or not is actually to contact their local blood center. Many of us have exempliversity.org. We have information online about eligibility. And you can also give folks a call and they will help you deal with a specific question that you have.
That's great. So just knowing that that local blood center in your community is a resource and a resource that will help you identify if you or other friends are eligible is important to understand. Dr. Ramsey, can you also speak to some of the changes in the deferrals?
Yeah, there's been some changes, some opening up of the deferrals, partly because of COVID and the recognition by the FDA that this is going to be a challenge for the blood supply, and so some of the restrictions have been lifted. For example, if you've been deferred because you were a long-term resident in Europe several years ago, that has been changed now, and if you were deferred before, you can contact your blood supplier to ask about getting reinstated, and there are other examples of that. I think it's very important for, as we've been saying, it's very important for constant blood donors. I think everybody probably knows someone who has needed blood transfusion. If you think about your family, your friends, someone who's gone through cancer therapy or difficulties with childbirth or gone through a an auto accident or something like that. Probably everybody knows someone who's needed blood at some point, and that blood had to be there for them to be able to pull through their situation. And so if if you think about it, we all have a lot of demands in our time, but if you think about it with regard to family or friends that you've know of who've been have needed blood transfusions in the past for medical problems, I think that's a perspective to carry forward and discuss with friends and family as well.
One thing I think that can be important for folks to remember is how much one donation can affect patients. So one donation of blood can actually affect more than one patient. Do you want to tell me a little bit more about that?
Sure. It's sort of the traditional saying, one donation can save 3 lives. That's because we can take a donation of whole blood, for example, and split it into the different products. So someone who needs plasma, someone who needs red cells, so on. Also, we have some automated methods of donation where someone can donate more than 1 unit of a specific component if they qualify. So we're able to really shepherd and help use those units to the best of their ability and really steward that.
So it's not just a one-to-one.
Correct. You can touch more than 1 life at a time.
That's amazing. So as we know, of course, there's no substitute for blood. So pathologists, the physicians who lead blood bank operations, how do they really maximize using this precious life source as efficiently as possible? Dr. Karp, do you want to start?
I think as a pathologist, I always say that I speak both lab and physician. And so I function almost as a translator. And I think blood bank is one of those areas where that happens probably more often than not. I spend most of my day talking to my colleagues in the laboratory to make sure, what our inventory is, what's coming in, what's going out, what are we, the most critical on, if we're critical at all. And then conveying that information to my physician colleagues in a way that they understand. They don't live in the blood bank, they don't live in the laboratory, and they haven't had the benefit of all of our extensive pathology training, so I have to make sure that they truly understand the limitations and really manage their expectations for what's possible and unfortunately sometimes what's not.
What is the most common incident where blood donation is needed? Dr. Cruz, do you want to tell us about that?
Well, most commonly, folks are transfused because they're receiving therapy for perhaps cancer treatment or sickle cell disease or other things like that. But then there is also where most commonly using a lot of blood products would be trauma.
So I think people think about car crashes, trauma, massive bleeding is when blood is most used, but I think it's easy to forget that it's the chronic illnesses too where a lot of blood products are used. So let's talk a little bit more about mass casualty situations. The blood bank obviously plays a huge role when there's a mass casualty, and sometimes there's a requirement that exceeds what's available in the blood bank. Dr. Ramsey, can you talk about how you manage through those kinds of tough situations?
Well, most people remember 5 years ago this month was the Las Vegas mass shooting.
Yes.
And in a few minutes' time, dozens of people lost their lives. But the survivors went to many hospitals in the Las Vegas area, and they used almost or probably over 500 units of blood products in 24 hours. So that's a tremendous demand on the available inventory. These units had been donated in the previous few days or the previous week or two, and they were already on the shelf waiting for the potential need like that. And so the lesson that we learned from these kinds of events is that the blood that's used in these events was donated the day or two or the week or two before, and so it's really important to have a constant supply of blood on the shelf because you never know when something like that would happen. It's a very challenging situation. Blood suppliers and hospitals work together to communicate on what their needs are. We have some models that have been developed to try to predict how much blood we're going to need. But we really need to. At the end of the day, it's really a lot of communication back and forth in terms of how much we need it, and and again, having that blood on the shelf already, because you never know what's coming around the corner.
Absolutely. What are the biggest concerns you all see that affect a local hospital's blood bank to prepare for these kinds of situations? I'll start with you, Dr. Karp.
That's a tough question. I would say that it's just the unpredictability, which I think was Dr. Ramsey was speaking to. We want to be prepared every day for what's around the corner, but sometimes, honestly, none of us really know. And so that's where, the preparedness comes in, making sure that we have policies and procedures in place. So when the unexpected happens, we have ways of handling it. But also just the unknown, on those days where the inventory is leaner than we would like, the concern that if something did happen unexpectedly, that, would we be prepared? And that's why it's so important for people to be donating constantly so that we are prepared for whatever comes our way.
I'm sure that all of you are in those situations in constant contact with the other caregivers taking care of patients in acute need,
Yep.
Working side by side with them.
Absolutely. There's a lot of phone calls back and forth to make sure that they know, where we are and that we know where they are as far as what their needs are and what we have available. There's also communication, I'm sure Dr. Cruz can say, between the hospitals and the blood suppliers, and with the blood suppliers and, larger scale infrastructure to make sure that the blood is where it needs to be, particularly in these mass casualty events that, are taking a large amount of blood in a very specific geographic location.
You're really kind of the invisible first responders in these situations, right?
To some degree, yeah.
Absolutely. So, Dr. Cruz, can you tell us a little bit more about patients who are interested in donating their blood, say, before a major surgery? Talk about maybe the pros and cons of that approach.
Sure. I will say that the best place to store blood is actually in the patient. We typically want to do those things when someone has a rare blood type or another compelling reason that they need their own blood. If they would refuse other blood as surgery, then certainly that's a concern. It's much better that folks are able to donate to the general supply because, as we say, all boats rise with the tide. And our inventory is such that we can then make sure that all patients are being treated rather than a single person.
So this practice that sometimes is called autologous blood donation, auto meaning self, right? Donating for yourself, is a practice that was popular, I think, maybe 30 plus years ago, but really has fallen out of favor largely, except for very specific situations like you described.
Yes, and certainly the blood supply is much safer than it was, at least as the concerns that folks had back 30 years ago. So it really makes more sense to use donations from regular donors who are, of course, qualified by eligibility questions and testing.
Thank you. Dr. Ramsey, would you like to weigh in on that?
Well, related to that is the pathologist's role in promoting the avoidance of transfusion. We promote what's called patient blood management, where surgeons, physicians for the patient, look to correct their patient's anemia, to correct their bleeding problems or bleeding tendencies before surgery, for example, so that they can get through their surgery without even needing blood. And that's really a key part of what we're doing. Also, for example, diagnosing iron deficiency and other kinds of anemia to treat those in advance. Or even treat them during the patient's unexpected hospitalization, so that they can avoid transfusion as much as possible. So that's kind of taken precedence now over the previous emphasis on autologous transfusion. Basically, the best transfusion is the one that's not given, I guess. Is the safest transfusion, as they say, is the one that's not given, and so that's where a lot of effort go into. The other part of that is just using one unit at a time instead of 2 or 3 units, reevaluating the patient to see if they need that next unit rather than just automatically giving another unit.
Really treating that dose of blood just like you would treat any other important pharmaceutical that has both benefits but also side effects that need to be taken into consideration. And so pathologists are really part of the team that assesses patients before elective surgery, just as similar to anesthesiologists and the surgeons working with patients. Finally, I know that it cannot be stressed enough why it is critical that people continue to donate blood, and more importantly, donate regularly. Dr. Ramsey, do you want to speak to that?
Yes, it's been again, as we've been saying, it's been a challenge for the blood suppliers and hospitals that collect blood to do the same kinds of blood drives they've had in the past. So it really is important for the public to take action in this regard, and seek out opportunities to donate blood. Again, it's vital for the entire medical enterprise, and there's no substitute for blood, and it's really a generous way to help out your fellow community by donating a blood. It just takes a few minutes, and you can have the satisfaction of helping several patients in your community.
Thank you. So we have some questions from our audience. So Dr. Karp, I'll direct this first one to you. This is from Joyce Frieden at MedPage Today. What effects have the COVID pandemic and the monkeypox outbreak had on blood donation, both in terms of how many people donate and in terms of changes to donation guidelines?
I'll take COVID. COVID has really changed how we do a lot of things, both in our personal lives, but also obviously in blood banking and in transfusion medicine. It really evolved just as the pandemic did. I think the things that we struggled the most with is making sure that donors felt comfortable to come donate with all the COVID restrictions, masking, and so on that occurred. Obviously, there were lots of changes to donors' lives, where they work, where they play, where they pray. And so that impacts where we're able to collect blood, because those were all places that we did collect blood. And in some cases, either the donors weren't there for a prolonged period of time, or in some cases, they have not returned. And so that really has impacted how we look at things. And then just moving forward with COVID, I think the concern is that people might not return to those habits, that a lot of our lives have just changed irreparably, and if we can't adapt blood collection to those changes, that we will continue to struggle. And we need to change, but we also need people to recognize the importance of coming back to us just as they were before the pandemic.
Yeah. Well, before we're done, I want to make sure I give Dr. Cruz an opportunity to talk a little bit more about the different parts of blood. We touched on this a few minutes ago, but again, one donation can affect potentially 3 patients. So can you tell us a little bit more about not just red cells, plasma, but also platelets?
Sure. So you make red cells, plasma, and then a subpart of the plasma that is a little bit more concentrated to help with clotting and coagulation, and then also platelets. And certainly we have some very dedicated donors who specifically give platelets in an automated way, and we are dependent on those folks. Platelets are a magical cell. They help with the clotting. They have lots of other things that go on with them, and it's really, as we call it, liquid gold. So again, either a whole blood donation or an automated donation, whether it's platelets or whether it's what we call double reds, certainly is an opportunity to help and amplify your impact on your community.
And you call it liquid gold not only because it's super precious, but because it actually has a golden color, the platelets.
That's
do
right.
When
When
they're donated. Can we talk a little bit more about why gay men could not donate blood during the HIV crisis and how that's recently changed? The thinking on this is evolving. I'm going to direct this one to Dr. Ramsey.
Right. This was a longstanding deferral going back to the onset of the AIDS pandemic, in which gay men were at risk for the HIV infection, and it was decided there would be a deferral for those persons for donating. More recently, this is changed to a 3-month deferral currently for men who have sex with men, base it on gender. And so the FDA is funding a current study to look at this question to try to evolve our donor questions in that direction. And over a period of time, we hope to get to the point where there will be not a gender-based deferral, but a deferral based on a risk behavior, and this would not only not only allow very some more dedicated donors to be able to donate, and it would also help the blood supply in an important way. So we're supporting this effort that's going on in several blood centers to work on this with the FDA, and we're looking forward to the results of that study and the evolution of this issue as we go forward. So stay tuned for further details on that in the coming months and years.
That's fantastic. So the goal being to make sure that we continue to have the safest and most ample blood supply possible. Thank you all so much for the friendly conversation and joining us today.
Thank you.
Stay with us. We'll be back for more hot topics after a short break. Welcome back to the College of American Pathologists Media Briefing. Joining me now are CAP members, Drs. Kalisha Hill, Bobby Pritt, and Donald Karcher. Please briefly introduce yourselves to the audience. I'll start with Dr. Hill.
Oh, my pleasure. Yes, I'm Dr. Kalisha Hill. I am a proud governor of the College of American Pathologists. I am also Regional Chief Medical Officer for Ascension, Illinois, St. Mary's in Kankakee, and St. Joseph in Joliet. I am also a practice owner and medical director for pathology and laboratory services at St. Mary's in Kankakee.
Hi, I'm Dr. Bobby Pritt. I'm a pathologist and also a proud member of the Board of Governors for the College of American Pathologists. My specialty is microbiology, and I am the chair of the Division of Microbiology at Mayo Clinic.
Hi, I'm Don Karcher. I am currently president-elect of the CAP. I'm a hematopathologist, and I'm professor and immediate past chair of pathology at George Washington University in Washington, D.C., where I still practice full-time.
Thank you all for being here. So let's begin our discussion with something that is concerning to all pathologists and really should be concerning to all patients too. And that's the staffing shortages that are affecting our clinical laboratories. You know, the pandemic took a toll on several industries, and clinical laboratories were certainly no exception. We do have data from the CAP Practice Characteristics Survey to share. Nearly 60% or more of practice leaders responding to the survey said it was difficult to hire laboratory staff. Among the greatest level of difficulty was hiring medical technologists and clinical laboratory scientists at 78%. So, Dr. Pritt, can you start off by explaining the job of a medical technologist and clinical laboratory scientist? How crucial are their positions in the clinical laboratory?
Sure, I'd be happy to. They are crucial, essential members of our staff. So medical technologists, many of them have a degree in clinical or medical laboratory science. They are highly trained professionals that perform the tests in the clinical laboratory, such as my lab, clinical microbiology, clinical chemistry. They're performing the tests under the guidance and supervision and direction of a pathologist, and without them, the tests would not be done.
Wow. We all work, right, in a clinical setting. So how concerning is this to you, Dr. Karcher? I mean, laboratories are busy places. So what difficulties does this ultimately pose to patients?
Well, at my institution, George Washington University, we, like most other laboratories, have really suffered in not being able to recruit enough clinical laboratory scientists, medical technologists, technicians, histotechnologists, the whole range of staff that actually do the hands-on work in the lab. What this has done is made the job of our remaining laboratory staff that much more difficult, more challenging for them to keep up with the very high volume of COVID testing and the wide variety of other testing that we do in the laboratory. This can delay the results of these tests from getting to the physicians who need those results to determine the treatment for their patients. So clearly this impacts patients in a very significant way.
So it may be invisible.
Impacts patients in a very significant way.
So it may be invisible to most patients, but it's certainly really important. Mm-hmm. So Dr. Hill, you and I both work in hospitals as chief medical officers, and we worry about these shortages too, certainly. Can you tell us a little bit more about how your organization is dealing with these issues?
Absolutely. We find the greatest benefit to be our partnership with local schools. And that's very important because my hospital is rural, and therefore there are several community colleges in the area where people are born in the area, they go to school in the area, and then they eventually work and stay in the area. And so we have generations of families that have been in that community for decades. And that really does provide an opportunity for us to build relationships. And so we very often will reach out to the class that is graduating or do career fairs in the school and try to recruit those students to our hospitals directly.
I can tell you that we have also found those relationships with community colleges critically important to keep that pipeline, as it were, flowing.
Absolutely.
Another concern are actually difficulties actually hiring pathologists, the physicians who work in the laboratory. Almost 2/3 of practice leaders in our survey, 65%, say that hiring pathologists was more difficult in 2022 than in previous years, which brings us to an important initiative the CAP created called the Pathologist Pipeline. Dr. Karcher, can you help us understand this initiative a little bit better and maybe explain why the CAP feels so strongly about it?
Sure. So the need for pathologists is greater than ever. With our aging population, with more complex diagnoses, more cutting-edge laboratory tests that we're doing in the laboratory, the need is really, the demand for pathology services and pathologists is really growing. So in order to meet that need, the CAP started the Pathologist Pipeline Initiative. Through this initiative, we are trying to get the word out to students to consider a career as a pathologist. We want to make sure that students understand that being expert diagnosticians, laboratory directors, is interesting work. It's very rewarding. It's downright exciting, given the incredible cutting-edge things that we're doing. So we're very hopeful that this initiative is going to result in a larger number of students considering pathology as their career choice.
So speaking of, considering pathology as a career, we all have stories about how we got to where we are, but I'd like to hear from each of you. How did you become interested in being a pathologist? I'll start with Dr. Pritt.
Oh, sure, Dr. Volk. As someone with a background in art, I was initially attracted to pathology because of how beautiful cells and microorganisms look under the microscope. But I was also very excited about the technology, as Dr. Karcher said, and the opportunity to work with other physicians as just an integral part of the healthcare team, really guiding other physicians into how to manage and be able to treat and care for their patient.
That's awesome. Dr. Hill, can you tell us your story?
Oh, yes. So pathology is one of those specialties where hands-on approaches are the best way to get people interested. So I was very fortunate to have a gynec surgeon who, in the middle of the surgery, would remove the uterus, take it down to pathology, and the pathologist would open, explain, and I watched the surgeon be in awe of the pathologist as she's explaining what she's seeing. And after about a week of this, I stopped going back up to close, and I stayed down in pathology with the pathologist and got to follow how that specimen went from something that was in the patient to slides on a microscope for the pathologist to make a diagnosis. So when I was looking at various specialties and I read in the residency book that the pathologist was the doctor's doctor, that had firsthand truth for me because I saw how the physicians really relied on the pathologist and the guidance they provide.
Dr. Karcher, we'd love to hear your story as well.
Sure. So what Dr. Pritt mentioned is certainly part of what attracted me to pathology. And a lot of folks who consider pathology love the pattern recognition and the sort of the artistic aspects. But for me, it was another thing. Really early in my career, I realized how much I love the challenge of making a diagnosis in a patient, solving the clinical puzzle that gets us to the root of what's really wrong with the patient. Successful treatment starts with a correct diagnosis, and that's what we pathologists do all day long. I also love the technology that we dealt with even when I first got into pathology, which has just exploded in sort of a high-tech aspect now. Molecular analysis, digital pathology, even artificial intelligence now is very much becoming part of our practice. So those are the things that attracted me.
I'll just share that some of the things that attracted me was not only were we able to consult with so many different other specialties playing that doctor's doctor role, but we're, the patient's doctor and get to touch so many patients. I think pathologists, again, unknown, to many, touch more patients than any other specialty because the clinical laboratory is involved in pretty much every kind of care a patient receives, be it in the outpatient setting or in an acute care setting like a hospital or an emergency room. Something else that is really important to CAP members is health equity in medicine. Recently, a new equation has become available when testing for what's known as EGFR, or estimated glomerular filtration rate. This is a test to evaluate kidney function or kidney disease. And racial bias has actually figured into how these rates were calculated and interpreted, especially as it applied to the African American community. And we have a story we'd like to share about this topic, and we'll share that with you now.
So my father was a fireman for Gary, Indiana. He was a very proud man. He fought in Vietnam. He was essentially my hero. Unfortunately, I feel he wasn't given the best attention in regards to his kidney disease. No one would have him see a specialist. And I remember my mom fighting very hard for him to see a nephrologist, and no one would take him until it was, too late. So EGFR stands for estimated glomerular filtration rate. It is a way that physicians see how your kidneys are functioning. There are certain stages of chronic kidney disease, and this EGFR gives you an idea of what stage you are in. The misconception started with the assumption that African Americans had more muscle mass, therefore they made more creatinine. And as a result, a coefficient or a factor was used in the equation. And this equation gave the misconception of less severe kidney disease in African Americans. And so that makes them ineligible for certain medication regimens, transplant lists, things of that sort, when they were actually more severe than how they appeared. A person would meet all criteria of needing a renal transplant. However, their EGFR was too high. And so that would disqualify them from transplants that they rightfully should have had. A new equation has come out. It is the 2021 chronic kidney disease EPI equation, and they've redone the equation so that there isn't a discrepancy between races. If I was a patient, I would ask my provider if the laboratory that is being used using the non-race-based equation. From what I'm seeing, most laboratories have changed over. And if they haven't, they're in the process of doing so. I mean, this is really great that this is being done because there's other instances in healthcare where there are race-based equations and race-based care. When it comes down to just that, I mean, how many lives that have been impacted? Maybe my father would have truly benefited from it. You're taking away the option for someone to get as much care and opportunity for survival. Anytime I get a chance to bring awareness to anything, to be an example, and to honor my dad in some way, and to help that no one else has to go through that.
This is an important change, and one the CAP feels should be used by all laboratories. We'll start with Dr. Pritt. What are your thoughts?
I agree. This is an important change. We are physicians, we're scientists. We need to base our testing and how we report our tests on science.
Dr. Hill.
So this strikes home for me because I have a good friend who was on the transplant list for 5 years. And she finally did receive her kidney transplant and now is very active in the National Kidney Foundation doing just this education so the community at large understands to look for the proper EGFR testing and making sure that they're not being excluded from their opportunity to be on a transplant list. So this is something that our laboratory implemented as soon as it was available back in the spring, and we've made sure that our patients within our hospital system receive the accurate reference ranges for this test.
That's wonderful. So, laboratory testing for the transgender community, when it comes to reference intervals, is another important change welcomed by the CAP. You know, when the science isn't right, we've got to fix it. Why is this change important, Dr. Karcher?
Well, this is very personal for me. I have a close family member who is transgender, and many transgender people are on hormone therapy or receive other gender-affirming treatments. And those treatments can actually change the reference ranges for some laboratory tests. The reference ranges are the normal ranges that allow us and other physicians to determine if a test result is normal or abnormal. And of course, that can really significantly impact whether or not a patient gets treatment and if they, and which, you know, make sure that they get the correct treatment. I'm very proud of the CAP and frankly the entire laboratory community that is now diligently working to make sure that we're using the correct reference ranges for all people, including transgender people.
All right, well, let's switch gears and talk about the latest on COVID-19 now that fall has arrived. Last week, Europe saw COVID cases rising, while vaccination and booster rates are falling. In Australia, where they are just coming out of their winter months, they actually had the worst flu season they've had in years. We are also dealing with COVID fatigue and information overload here in the United States. So let's break things down when it comes to COVID-19 and new testing guidelines. I would like to discuss the most recent testing recommendations, the change in testing recommendations released by the FDA. The recommendation says that if you believe you were exposed to COVID or have symptoms, you should test, wait 48 hours, test, and wait another 48 hours and test again if all those tests are negative. Dr. Pritt, why are they suggesting testing this way with rapid at-home, the rapid antigen tests that are done at home?
Sure. Well, first I'll say that the testing guidance is a little complicated, but it's really nicely laid out on the CDC's website. And the CDC's worked closely with the FDA, who realized early on that those rapid antigen tests are just not as sensitive as our gold standard PCR test. And those are generally the tests that are performed in the clinical laboratories. So patients enjoy having a rapid test available to them. It's easy, it's convenient. But if the test is negative, that does not exclude infection. So we're more likely to see a false negative result. And that's why the CDC and the FDA recommend that if a test is negative, you can't use that one result to rule out infection. And they recommend waiting 48 hours and testing again.
Are people using these at-home tests correctly?
I would hope so. Of course, I can't guarantee that, but I would say that the tests that have been developed and have received emergency use authorization by the FDA for at-home or patient use have actually been scrutinized to make sure the instructions are well written with nice pictures and easy to understand text. And so if people are following the instructions, they should be able to accurately perform the test themselves at home.
So that's a big if,
yes,
right? Following those instructions. But again, I think emphasizing to the folks at home, it really is important to read those instructions and give that test the time and respect that it needs.
Right.
To
Even
get the
if you've
best
done a
result.
test before, you can't just try to do it from memory. I've taken multiple tests. I still get the instructions out each time and follow it step by step.
Excellent. And you're an expert in testing and still do that. So Dr. Hill, can you tell us a little bit more about the difference between the rapid antigen tests that are available for home use and the more sophisticated tests that are available in the laboratory, the PCR test?
Absolutely. And we've talked about this from the beginning of the pandemic, trying to develop that gold standard. And so once all of us validated PCR testing for COVID-19 in our laboratories, we recognize that that's the gold standard. But as a pandemic evolves and we need more access for testing, then the antigen tests do play a very good role in making sure you can test people quickly. So the CDC recommendations are very helpful in that it appropriately recognizes the limitations of an antigen test. By testing every other day and doing serial testing, you increase the sensitivity of the test. Whereas if you have a PCR, the PCR is so sensitive that very likely as soon as you start having symptoms, you will be positive, where an antigen test may be negative. So I know all of us have personally experienced that we've gone to a party, found out someone tested positive, and then we get some test kits from Walgreens, go home, take our test, and then it's negative. And then a couple of days later, we're still having symptoms and we're negative. And it's like, oh, it's negative, but then you may have more severe symptoms, and then you go and actually get a PCR and it's positive. So it's very important that if you do see your symptoms evolving, to go ahead and get that PCR, because you may never turn positive with an antigen test.
Oh, thank you for that good explanation and that experience. Dr. Karcher, we will certainly be expecting some new COVID variants coming this fall and winter. Why is it critical for people to continue to take testing seriously when it comes to dealing with this virus?
Well, you mentioned COVID fatigue, and that is a reality out in the community. This is a very clever microorganism. It keeps mutating, and new variants keep emerging. We're fortunate to have vaccines now that are targeting specifically the most common variants that are in the U.S. currently. However, even though we have vaccines, it's very important to continue to test because it's the best way to stop spread of this virus in the community. If a person maybe is having COVID-like symptoms, or if maybe they think they've been at a party and maybe been exposed to someone who, with the infection, it's very important that they test to see if they're infected themselves, following the protocol as was outlined with 48 hours and wait 48 hours and wait 48 hours. Because only by doing that can they avoid unnecessarily exposing other people to the virus if they are in fact infected. And we know that this is really the best way to stop spread in the community, is to, even with vaccines, which we'll talk about in a moment, are a great advance, but we still need to stop the spread in the community, and that testing is vitally important.
Still speaking about testing, how about making sure those tests are not expired when you have them at home, and that you've got enough on hand? Dr. Pritt, do you want to talk about that?
Sure. Well, first, having enough on hand is great, although often you can go to your local drugstore and pick some up, but it is nice to have a couple at home. That way you don't have to go out and about if you think you might be infectious to others. But you need to check the expiration date, because if they've been sitting there for a year, it could be that they've expired, and then you can't trust the result. So that's another important thing that people have to keep in mind when they're doing their own testing at home. That's the sort of thing that we look for regularly in the laboratory. We're always checking expiration dates and temperatures and storage conditions, and now we're asking patients to do that.
We don't want to underestimate the flu season. After 2 years of lower flu rates in the United States, largely because of some of the COVID prevention methods like distancing and masking, this year we're predicting that this could be significantly worse than expected, up to 3 times worse than in the past. Dr. Hill, why is it vital that the public continue to take the flu as seriously as they take COVID, and make sure we get not only the COVID vaccine and booster, but the flu shot also?
Absolutely, and I think the reason it's more important now than ever, because so many of the symptoms of COVID-19 overlap with the flu. So if you're having symptoms of one, you're not sure if you're positive for COVID, and then you may still be going out and you spread. So it's very important that people are monitoring their symptoms and still testing. The best thing anyone can do is to get vaccinated. I got my 3rd booster and my flu before I came to this annual meeting where I'd be around 1,200 people. And so I encourage everyone to get both vaccines. You can get them the same day, you can spread them out. I did one in one arm, one in the other arm on the same day, and it worked just fine. So it's very important that people are vaccinated. And then the second component of this is recognizing we cannot go back to the days when people would just say, oh, I'm going to tough it up and go into work, when they're sneezing and coughing and literally spreading germs across the entire office. We simply cannot do that anymore. So I anticipate that virtual platforms are here to stay. If you're having symptoms and you need to be in a meeting, you need to call in or do a Zoom. Just to make sure that we're not bringing germs. But at the same time, people like to be in person. So we want to make sure that we're being safe, that we're gathering and keeping each other safe by getting vaccinated and staying home when we have symptoms.
Thank you for that. Now, Dr. Pritt, some people think that being up to date on our COVID vaccines and boosters means I don't have to worry about doing a flu shot. Can you tell us a little bit more about what your thoughts are on that?
Sure. Unfortunately, that is not the case. Speaking as a pathologist who specializes in microbiology, I can say that influenza is caused primarily by influenza A and influenza B viruses. That is completely different than the SARS coronavirus that causes COVID-19. They're 2 different viruses. They're not well related, not closely related, and you need separate vaccines for both of them.
So this brings us back to the importance of vaccinations. Unfortunately, there's still plenty of misinformation out there. The number of people getting vaccinated and boosted for COVID is down both in Europe and here in the States. I'd like to hear a little bit more about how you all feel about this disturbing pattern, given what's going on with COVID rates in Europe and the flu in Australia, and how important the vaccines have been in curbing hospital admissions and the stress this plays on your clinical laboratories. Dr. Karcher, I'll start with you.
Yeah, you know, the low vaccination rate is very disturbing, and particularly, and you mentioned about the misinformation about it. We know from the science that these vaccines work. They're safe and effective. And I mentioned earlier that we now have targeted vaccines that we're all getting boosted with that are targeting specific newer variants that may be more infectious than, and are more infectious than some of the earlier variants. The other thing that we know about these vaccines is that even when a person gets infected, it keeps infected patients out of the hospital and particularly out of the ICU. So this not only saves lives, obviously, but it also decreases that stress that you mentioned in our hospitals and in our laboratories that allows us to better care for patients with other diseases. So it really is a benefit both for the patients themselves and the healthcare system.
Dr. Hill, would you also like to comment on that?
Yes, so we had firsthand experience with this because many of our counties in many states, not just mine, celebrated when we got to a 50% vaccination rate because there was so much misinformation and people not wanting to get vaccinated. So we did a lot of education in the community and really trying to explain to people why it's so important. And I think it's crucial right now because we're at a point where our hospitals have had some of that pressure released. Over the summer, our last big surge was in the spring. So as we go into the fall and we have this collision of possibly flu and COVID, it's so important for people to be vaccinated so that we do not overburden our hospitals. Many hospitals are already short-staffed with nurses and PCTs, and so it's very important that we don't stress them even further. So that's why being vaccinated is so important to decrease your morbidity so you do not end up admitted in a hospital.
So really what I'm hearing you all say is that being vaccinated not only is good for an individual, but it's also really part of being a good citizen and a good neighbor. Another really concerning issue to the medical community is the resurgence of polio. We conquered polio decades ago, but now we're facing it again, even though we have a perfectly good, successful vaccine. So, Dr. Karcher, why is this so concerning?
So yes, there has been an emergence of polio in this country and other parts of the world, and it's very disturbing. I've been around long enough to remember the terrible impact of polio in the 1950s, when my classmates in school became seriously ill, some of them, and some of them terribly paralyzed as a result of this. So we cannot let this disease that, as you mentioned, we conquered, yet not fully conquered. We do have an effective vaccine for this. However, in some parts of the U.S., the rate of vaccination is really surprisingly low. The area in New York State where there was the recent emergence of this case, the vaccination rate is about 60%. Now, this partially may be to do with the pandemic, and maybe people were reluctant to bring their kids in to get vaccinated, but it's at least partially related to the continuing misinformation about vaccines in general, and even specifically this very effective polio vaccine. Traces of polio have even been found in the wastewater in these communities, which means there are undetected cases of polio that are spreading in the community. The best way to arrest that spread is to increase the vaccination rate. We cannot let polio reemerge in this country.
Couldn't agree with you more. Well put. Well, let's not forget about monkeypox. Now, the good news is cases are declining. And again, that is largely because people in high-risk groups are accepting the vaccine and getting vaccinated. The other thing is, if dealing with all these other viruses isn't enough, Ebola is now reemerging in Africa. What are your concerns about this recent outbreak, and what could it mean for the United States? Dr. Pritt.
Certainly. Well, it is a potential concern, and the FDA just recently did have an alert that they issued about people coming from Uganda, where the current outbreak is. We've certainly seen outbreaks that have reached the United States before with Ebola. At this point, it's a relatively low risk, but it is something to consider. Ebola is a virus that is zoonotic, meaning that it is in the environment with animals as the primary host. In fact, I'm not really sure what the actual host is. And so this is not something like polio that we can get rid of. It'll always be with us. And we have to keep in mind, we are truly a global society. You can circumnavigate the globe in less than 2 days at the circumference of the Earth. And so you could quickly travel from an endemic area to any part of the world. So we'll always have to be on the watch for old, new, and emerging pathogens.
Great points. Dr. Hill, do you have anything to add?
Yes, I think Dr. Pritt explained it very well, and it's just being mindful as we continue to screen. We've been through this before, and actually was mitigated very well. I remember the cases. I went to Emory undergrad, and I remember Emory taking care of that patient. And it's just so important that we're vigilant, that we're screening in airports, and that we're making sure we're keeping the people coming into the country safe, as well as the people in our country. And so just having that awareness and recognizing it is low risk, but that we're doing appropriate screening.
Wonderful. So that was a lot of information to digest. I'd like to take some questions from reporters in our virtual audience. The first question we have is from Carla Johnson at the Associated Press. What do you think about swabbing one's throat or inside the mouth with a rapid antigen COVID test? So Dr. Pritt, I'll start with you.
Sure, I can comment on that. That came up early as a potential question, especially with the Omicron variant. There was some concern that it might be more present in the throat, but it turns out that testing with most of the antigen tests that are available using the approved specimen is still the best route. And I would say in general, you don't want to go off label. For a test that's received emergency use authorization, you want to stick with the instructions that come with the kit.
Okay, wonderful. Let's see if we have another question that would be on a different topic from our virtual audience. Dr. Pritt, when it comes to swabbing following the instructions, again, like you said earlier, is really critically important. So again, using that instrument in the way that it is meant to be used, right? Do you want
Yes.
to talk again a little bit about why
Sure.
that's important and why those tools are designed to be used in the way that the instructions actually?
Yes, I'd be happy to. The tests that are available over the counter for patients to use have been evaluated in a very specific way. And what we know about them, how good they are or how bad they are at detecting a disease, really comes down to the exact method of how the collection is supposed to be carried out. And if you start deviating from that, add one drop or two, collect one source versus another, you've basically invalidated the test and you really can't trust that result.
Okay, so again, I mean, getting the best result means following those instructions to the T. Okay, from Joyce Frieden at MedPage today, regarding COVID test expiration dates, didn't the FDA extend the expiration dates for some tests? Dr. Karcher, do you want to talk a little bit about that?
Yeah, as Dr. Pritt mentioned earlier, the importance of not using tests that have expired. But if you have a home test kit, and maybe the date expired, you can actually go on the FDA website and they will list extended expiration dates for some of the at-home tests, because it's been found that some of the tests maybe haven't fully expired, and that date can be extended. However, it's really important to verify that your test is one of those that the expiration date has been extended.
So FDA.
Not all tests, just the specific test that you might have at home.
So FDA.org, or excuse me, FDA.gov to find that list if you have a test that you might think is expired, but maybe they've extended the date, you can double check. Dr. Pritt, a question from a viewer about polio vaccine. She's 65 years old and did receive the polio vaccine as a child, but she's worried, is she still protected?
She should still be protected. That is correct. If you've received the full vaccination schedule as a child, then she should still have protective antibodies.
Okay. And then, Dr. Hill, are you getting questions from folks at your hospital, where you're at the hospitals where you're chief medical officer, about protection from childhood vaccines that maybe were given many, many years prior?
So most of our vaccination conversations do talk about making sure that you're getting your childhood vaccines through adulthood, and the ones that require boosters, that you're getting those as well. And fortunately, as I stated, being a small community hospital, many people who work in the hospital also have their friends or their cousins, and so their vaccination records are required by the hospital, and so they're able to trace back to make sure that they actually had all of their required immunizations. And that's how that education is very prevalent. Oh, then I know as a nurse I need to make sure that my daughter gets her childhood vaccinations. And so that's very important to make sure that everyone is receiving those.
Thank you so much. Well, before we go, on behalf of the College of American Pathologists, we would like to urge everyone who is eligible to get the COVID vaccine, get the boosters that go along with it, and when it's time, get a flu shot. Also, please continue to take testing seriously to keep you and your family safe. We really hope you have found this enlightening, and that we provided you some insight into exactly what it is pathologists do and the extensive reach of our work across all of medicine. A recording of this media briefing will be available shortly at cap.newsroom.org. As well as more information on these topics. On behalf of the College of American Pathologists and our members, I want to thank our guests, but I'd also like to thank you for joining us today.